We're going to talk about altered mental status in the found down patient. I don't have any disclosures to make. I've been through airport security so many times that they recognize me each time that I go through. My learning objectives: talk about the differential for found down, choose the best imaging for each patient. Most of the time it's going to be CT. If that doesn't give you the answer, you get an MR scan. I want you to recognize imaging findings that are going to acutely change patient management, because that's actually what we're doing this for. And we're not going to have time to talk about having a checklist. So that's what we're going to talk about. So I want everyone to think about the things I'm going to show you as being what triggers you contacting the ER doc and telling them that this patient really needs a lot of attention. And I want to talk about the 4 H's. And we talk about this. We talk about the 4 H's of the neuro-apocalypse. We have hemorrhage, we have hydrocephalus, we have herniation. Those are the 3 that everybody knows. And then I added one: hypoxia and infarction. Okay? And infarction is that Hirninfarction is actually the German word for infarction. So I had to put that in there. So these are the things that we have to think about. So, just some examples of them I'll show at the beginning, and I'll come back and show them again later on. Hemorrhage, that may give you a headache as well. Herniation, major subfascial herniation from a mass lesion here. Significant hydrocephalus for this patient. And then here's a patient that had global hypoxia and ischemia. So we'll come back and talk about this at the very end. But I want to get into some of the things that are a little bit more interesting and a little bit more difficult, but that I want to tell you a trick. So the patient comes in with symmetric or diffuse lesions. You have to always think about some kind of a toxic or metabolic cause, or maybe the patient has some metabolic problem that's caused by a genetic disorder. Those things almost always involve the gray matter more than the white matter. So we're going to primarily be looking at gray matter lesions. Now I want to tell you guys, some of you are old enough to remember Ben Felsen. Ben Felsen used to talk about interstitial disease, and he did dual projection, and he would have the image on one side and the diagnosis on the other. And he did this little trick. At the end of his lecture, there would be one slide blank, and he would say, "Oh my God, I've been out of sequence for the entire lecture," trying to tell everybody that interstitial disease really looks the same. And a lot of these toxic and metabolic diseases can look the same. And so what you're going to do when you see the abnormal image is going to say, this is something toxic or metabolic. You need to do a tox screen. You need to do electrolytes for this patient. You need to pump their stomach to see what's going on. Because I can tell you what it might be, but I can't prove what it actually is from looking at the imaging. So I could show you a whole bunch of things, and you would get that same kind of thing. So look at this here. All of these patients have gray matter lesions in different kinds of locations. These are all different kinds of toxic metabolic scenarios. And so if you want to just walk back from this, you can just say, it's something toxic or metabolic, and I don't know exactly what it is, but you need to do the lab work to find out what it is, or you need to pump the guy's stomach to see what they've ingested. So I don't want to tell you you can't do anything, but I want to be practical for it. So I want to start out with a couple of clinical cases. 41-year-old woman found unconscious at home, no signs of trauma, no pills or anything else. These are what the CT scans look like. So this was a telephone consult without the imaging. And one of my friends called me up from an Air Force hospital and said, "Jim, I've got a woman who's unconscious and she has a funny looking CT." And I said, "Is it funny looking ha-ha or funny looking strange?" And she says, "All the white matter is abnormally hyperdense." So I'm immediately thinking about calcified leukoencephalopathies and all kinds of bizarre things like that. And then I said, "Is it really that the white matter is too dense, or is it that the gray matter is too lucent?" And there's a pause on the phone, and she goes, "Oh, maybe it's all the gray matter is too lucent." And I said, "Is it everywhere?" And she goes, "Yeah, it's pretty much everywhere, and it's pretty much just the gray matter that's abnormal." So I said, I said, "Amy," because that's her name. I said, "Amy, I don't really know what this is, but it's something toxic or metabolic. So you better do some lab work and figure out what it is." And by the way, I really love this case because you have that heart-shaped symmetric thing in the occipital lobes. So she has diffuse bilateral abnormalities, low attenuation, in the cortical gray matter, also in the basal ganglia. We know that gray matter edema is cytotoxic edema. And what does cytotoxic mean? Cytotoxic means that something is killing the cell. The energy-dependent, ATP-dependent intracellular pump, cell membrane pump, is not working properly, and you have water going into the cells. And when the water's in the cells, it can't move, and you get restricted diffusion if you had an MR. So this is cytotoxic edema, but I can't tell you exactly what the cause is, but I can tell you it's some kind of toxic or metabolic process. So we need to have either a good history or we need to have some lab value. So you could have all kinds of problems with drugs. You could have metabolic poisons, carbon monoxide, methanol, ethylene glycol, antifreeze, and you can have all kinds of electrolyte abnormalities. These are the things that you have to look for when the patient is down. And the tox screen and the standard metabolic panel are pretty similar, but not exactly the same in different situations. So this patient's serum sodium was at 121. So this is what was wrong with this patient. This patient had water intoxication. This was a psych patient who had psychogenic polydipsia, but overhydration can cause this. You can have a iatrogenic hyponatremia because they could give the patient D5W instead of giving them some salt every now and then. My mother, who's 99 3/4, has a chronic problem with hyponatremia, and my brother used to tell her to go to the ER, but now he doesn't do that anymore because now he just gives her a bag of potato chips because he knows it's most likely her hyponatremia that's going to be the problem. So this is a patient that had water intoxication. So you can drink too much water. It is a significant problem. And in the Marine Corps Marathon in the DC area, it used to be very common for 5 to 8 people to pass out during the Marine Corps Marathon because everywhere they went, somebody was handing them a bottle of water. They're sweating salt, they're drinking water, they get water intoxication. So it's something to think about, but it's a laboratory diagnosis. So the goal of treatment is to raise their serum sodium, but one of the things that everyone needs to be aware of is a disease that was invented and created by doctors in the 1950s, which was treating patients like they were lab rats, and you measure something that's too low, and you give more of that stuff to the patient. So these patients were hyponatremic, and we gave them salt, and we gave them too much salt, and then they ended up having a demyelinating disease called central pontine myelinolysis or osmotic myelinolysis, completely caused by us treating the patient as a lab rat. So what's the cause of osmotic myelinolysis? It's over rapid correction of hyponatremia. It damages the oligodendrocytes. The endothelial cells shrink. So it's sort of like pouring salt on a snail. I'm not going to ask you to raise your hand if you did that as a kid, but you want to realize that what we're doing with the patient is that we're over rapidly correcting something. So, when I was an intern in internal medicine, they told me, don't fix things any faster than they occurred. If somebody has become slowly hyponatremic, then correct them slowly. If they became rapidly hyponatremic, then you can correct them more rapidly. So that's what we need to think about. But what you're trying to avoid for this patient is some aggressive, newly minted intern or ER doc salting the patient up with 4 times normal saline and then causing them to have this, which will kill you, which is osmotic myelinolysis or pontine myelinolysis. So I just wanted to show you that. You get preservation of the corticospinal tracts because their neuronal cell bodies are not in the brainstem, they're someplace else. So this is a local effect on the neuronal cell bodies. Okay, let's look at another case, and you might actually save somebody's life with this case as well. 27-year-old woman. She had a gastric bypass 4 months ago with recurrent vomiting since the procedure, okay? So we've got this history of gastric bypass, and we're looking here at the scans, and there's no midline shift, there's no herniation here, there's no focal mass lesion, but there's an abnormality here in the medial part of the thalami, which you should probably learn to pick up. And if you're kind of sharper, you're actually seeing something here around the third ventricle. So this patient has a gray matter lesion. So what did Jim say? Not that you should believe anything I say, because no one should listen to me, like my grandson Jack doesn't listen to me. But it's like, it might be something toxic or metabolic. It could also be some kind of a viral infection. Normal midline structures here. So bilateral thalamic lesions. It could be infectious, West Nile encephalitis, and some of the equine encephalitis and Japanese encephalitis like the thalamus. It could be metabolic disease like Wernicke's encephalopathy. By the way, that's supposed to occur in street people who are alcoholics. It's not supposed to occur in people like us, but just as a reminder, people like us do bad things too, and we can be alcoholics. It could be a variant CJD, mad cow disease. By the way, people obsess about variant CJD. There are less than 300 cases of variant CJD reported in the literature ever. So if you do see one, let me know so I can make it 301, okay? But that's not that often. And then again, osmotic myelinolysis can also occur in the thalamus and vascular lesions. But after receiving thiamine, the patient's symptoms improve. So you got that history of gastric bypass, and this patient has B12 deficiency, and your body can only store about 2 weeks of B12. And how many of you went to medical school? Because if you remember being in medical school, they told you if you have an alcoholic patient, you want to give them the B12 before you give them glucose, because if you give them glucose without B12, there's something called the Krebs cycle, and they're going to actually get really sick when you give them the sugar without giving them the B12. So this is involved in B1, carbohydrate metabolism. Thiamine is not stored in the body, again, in 2 weeks here. This is something I want to highlight, which is gastric surgery. We heard about this yesterday. How many of you ever thought about hyperemus gravidarum as causing vitamin deficiency? Because it can cause a vitamin deficiency, and it's right up there, 12%, 17%. And so you need to think about that as well. In terms of the diagnosis of Wernicke's encephalopathy, it's not made very often in life. It's made at death by the pathologist. So if you don't think about it, it's less than a quarter of the patients are going to have the classic triad. So you want to draw the patient's blood, and then you want to give them the thiamine. So again, this is a big problem, but if you see something in the walls of the hypothalamus or something in the medial aspect of the thalamus and the pulvinar, you want to say, hey, listen, I don't know what this is. It might be toxic metabolic, but you're not going to hurt the patient by giving them one of those little yellow injections into their IV bag of vitamins before you give them the glucose. You might actually save that patient. So Wernicke should always be considered when a pregnant woman has persistent vomiting and neurological signs and symptoms. So I started out with the history of gastric bypass, but I wanted to make this connection here because this is much more common. Hyperemesis gravidarum is much more common than someone coming in with gastric bypass. 60,000 cases every year of the hyperemesis gravidarum. So, if you just have that history that the woman's pregnant and she's been throwing up a lot, you want to think about that. And again, what's the difference between normal morning sickness and hyperemesis gravidarum? It's interfering with their normal life. They're vomiting too much and they're losing some weight. And just as a reminder, I know that you didn't come to Orlando to see the Krebs cycle, but here's part of the Krebs cycle here. And if you have the B1 thiamine deficiency, then you block this pathway, and then you make the patient acidotic, and they have lactic acid buildup. So that's basically what's going on with these patients. But this is the classic appearance for it. You're going to have involvement of the medial hypothalamus, the medial part of the thalamus there, the pulvinar or the hypothalamus. We also have involvement of the tectal plate. And of course, everybody learned in medical school about the mammillary bodies being involved with that. So this is a patient that died from Wernicke's encephalopathy, and we have this brownish discoloration of the mammillary bodies and abnormally hyperintense and enhancing on that MR scan. So when you think about the causes of coma, you have to think about global hypoxia, hypotension, global hypoglycemia, and all kinds of drugs and intoxicants. So let's talk about some of those. And again, I want to emphasize bilateral symmetry, gray matter abnormal. Some patterns tell you what the toxin is, but basically it's going to be a biochemical diagnosis. Unconscious in his car in the garage the morning after driving home from a party, brought to the ER by the EMS. Here's a pair of CT scans that are done, 2 different slices. in this patient. You can see the abnormal hypoattenuation in the medial part of the lenticular nucleus. So that's the globus pallidus, and that's something we also learned about in medical school. If we look at the T2 weighted MR, again, you can see here in the medial portion of the lenticular nucleus, the globus pallidus, abnormal hyperintensity, not so abnormally dark on the T1 weighted image. Something else I want to highlight for you here, this is the posterior limb of the internal capsule. So maybe Jim is lying to us when he says that these are only gray matter diseases, because now we have a little bit of white matter that's abnormal here. And I think most of you know what this is likely to be. We have restricted diffusion here, so everything is pointing to the same place. So this is the classic appearance of carbon monoxide intoxication. Now, I was taught that carbon monoxide affects the medial portion of lenticular nucleus, the globus pallidus, because of selective vulnerability. That those neurons that live there are just more likely to be damaged by carbon monoxide than all the other neurons in all the other parts of the gray matter. So, okay, I memorized that because there's going to be a test and I want to finish medical school and go out and become a radiologist. So it's probably more complex than that because carbon monoxide is cardiotoxic. And it may be that the reason why that white matter in the posterior limb of the internal capsule is also abnormal is because that part of the brain has a very tenuous blood supply and perfusion pattern compared to the rest of the brain. And I actually was taught this by a neuropathologist 25 years ago who was working with the military medical examiner system. And he said, you know, we always see these white matter problems in patients that die from carbon monoxide intoxication. And then somebody told him that carbon monoxide is cardiotoxic. So it's probably the combination of things. It's not just the molecular toxicity at the cell membrane level, but there's also an element of hypoxia with carbon monoxide intoxication. So again here, this is not gray matter, but that classic localization. And carbon monoxide intoxication is very common. It actually looks like you're an alcoholic and you're drunk. There was an epidemic of carbon monoxide intoxication in New York City, I think in the 1930s. They were having these parties at the same house, and it had a leaky chimney. And so they would get 25 or 30 wealthy people showing up in the emergency room like they were drunk. And, you know, they would stay there overnight and then they would go home. And the next Friday they'd be back again. And they weren't intoxicated with alcohol. They had carbon monoxide intoxication. So you all remember again that it's the globus pallidus. You remember they have the cherry red macula. So if somebody actually looks at the patient's eyes with that thing that we call the otophthalmoscope, you guys remember those things, right? We almost never use them now. We use the imaging, but they would see that the patient had a cherry red macula. So carbon monoxide intoxication, and again, it can cause death there, and this is of the cells there, but can also kill the patient. So we've lost the normal gray matter color here of the globus pallidus. And, you know, it's very, very common. You can when I go back home, I'm going to pick up open up the newspaper on my laptop, and I'm going to see that people had carbon monoxide intoxication because they started their furnace for the first time because it got cold and they didn't know that a raccoon was nesting in the chimney and all of the flue gases are coming down again. So we talk about selective vulnerability, but it's probably more complex than that. Carbon monoxide binds to hemoglobin and makes carboxyhemoglobin, and the affinity is 240 times greater than that for oxygen, so you can't get rid of the carbon monoxide. How many of you have hyperbaric oxygen therapy where you are or near where you are? Because that's hypothetically what you're supposed to do to really rapidly correct these patients, is to give them hyperbaric oxygen therapy. And there's lots of people that are heavily invested in HBOT therapy. I suspect that just putting the patient in an oxygen tent and giving them normal pressure oxygen works pretty well. And I live in the DC area, and the nearest HBOT is in Baltimore, and somebody said, I'm going to kill more people putting them in a chopper and flying them to Baltimore than I am giving them the oxygen right here in my hospital. That's probably true. Something else to think about. All right, 23-year-old man brought to the ER, no prior history of drug use, etc., no other history available. He's comatose, pupils fixed and dilated, etc. He's in bad shape. I love Elliot, but I have to tell you, I like neuro more than abdominal imaging because in the head, everything is symmetric. You know, when I look at the abdomen, I have to remember spleen's here, liver's there, everything is kind of different, but in the head, everything's symmetric. But the downside of that is if you have symmetric abnormalities, you can't pick them up. Right? It's really good when you have an asymmetry. It's really bad when there's symmetric lesions. So this is actually symmetrically abnormal, but it takes a lot of experience to see that. So the abnormality here is involving the gray matter near the base of the brain, also back here in the occipital lobe. So you have these gray matter lesions. They're relatively symmetric. They're involving multiple parts of the brain. They're beginning to involve some of the white matter in some spots. And this time, it's the caudate nucleus, the lenticular nucleus, and the globus pallidus, and all of the thalamus. So this is again gray matter, and it's like, okay, I've got all these gray matter lesions. I've got something back here in the medial occipital lobe. You know, I'm getting restricted diffusion. Everything kind of fits together. So I have diffuse cytotoxic edema, but what's the cause? Some kind of toxic metabolic problem. I need to have more information about this patient. You have a differential diagnosis, all kinds of systemic things, drowning, cardiac arrest, asphyxiation, encephalitis, and again, toxic exposures and ingestions. It could be any one of a number of different things. And again, it can be hard to see because it's so bilaterally symmetric. So bilateral basal ganglia and thalamus, again, you could have something involving their common blood supply. You can have something metabolic from liver disease, hyperammonemia, non-ketotic hyperglycemia, all kinds of things it could be. But the question is, how are you going to figure out what it is? You're going to pump the patient's stomach, and you're going to find out what's in their stomach. What did they ingest? What kind of a history can you put together? Can you get a lab value that tells you what it is? So they pumped this guy's stomach, and he had antifreeze in his stomach. So this is ethylene glycol poisoning. Now, am I smart enough to say, oh, this is the classic pattern for ethylene glycol because I have caudate and I have the lateral lenticular nucleus and the thalamus? No, I can't tell you that. I also want to suggest something for which I have absolutely no proof, but that is I think that a lot of these toxins caused profound metabolic acidosis. And I think that part of the problem with profound metabolic acidosis is that all that deep gray matter is affected more often than the cortical gray matter. Because I think that that's kind of like the final common pathway from a bunch of different insults is to have a profound metabolic acidosis. So anyway, people talk about this lentiform fork sign. You know, I got to tell you, I'm Greek. It looks like a trident. Where's Poseidon? You know, but it's like I have to use my imagination to be able to see that lentiform fork sign. So ethylene glycol, it tastes sweet. So there's nothing bitter about it to make you spit it out. Kids will ingest it. Adults will ingest it intentionally. Dogs and cats and other animals will find it dripping under your car. It's metabolized in the liver. It gives the patient a metabolic acidosis. And this was the trick from medical school. They get calcium oxalate crystals in their urine. So if they did something really novel, like a urinalysis, it's possible that somebody would see crystals in the ER. And then again, people look for different ways to treat this, but basically, you know, you've got a patient with a profound acidosis. People tried to treat these patients with ethanol, which you also use to treat methanol intoxication, as well as fomepizole, which they also use to try to treat methanol intoxication, but doesn't really work that well. All right, 42-year-old man, alcoholic who works as a carpenter, found down in his workshop. And he has a profound metabolic acidosis when they did the electrolytes. And he's got something here which is sparing the thalamus, but involving the caudate and involving the putamen bilaterally. He also has some abnormal hyperintensity involving the white matter. So this, again, is some kind of a systemic insult. He actually has some hemorrhage going into the caudate and going into the putamina bilaterally. And this is the classic pattern that we associate with methanol intoxication, but any of the organic alcohols can cause a similar appearance. And this is, unfortunately, the autopsy showing that he has hemorrhagic necrosis in the lateral lenticular nucleus and in the caudate. So this guy was a carpenter, and methanol intoxication is something that we see when people drink methanol because they can't find ethanol. So one of my friends said he worked as a carpenter. He drank a solvent that's used to dilute shellac, and then he died with a great finish. But this is what you have with methanol intoxication. So this is a problem. There's a pattern there, and we can see the pattern. And this is a companion case. This is a patient that had cortical blindness, and he survived his intoxication. And he has this slit-like fluid cavities where the putamina used to be. I want you to notice that the occipital lobes are actually okay here for this guy. So I was at the RSNA 15, 20 years ago, and someone had a fantastic scientific paper on the occipital necrosis caused by methanol intoxication, which was a fantastic study, but the problem is that's not what happens. Methanol is directly toxic to the retina. It has nothing to do with the occipital lobes. And this case obviously proves that you can have A, methanol intoxication, B, you can have blindness, but it's retinal blindness, not cortical blindness, and the occipital lobes are okay here, and the guy survived it. So that's something else to think about. So just a couple of other cases. 24-year-old pregnant woman, drowsy, blood pressure is a little bit high. Once again, we have abnormalities in the deep part of the brain involving the lenticular nucleus, involving the caudate and the putamen, not so much the thalamus. Again, nothing specific here. How many of you have heard of this HELP syndrome? Has anybody here heard of this HELP syndrome? So this is what this patient had. So why does this look like the other things? It's not really a toxin. It's a profound metabolic acidosis. So maybe that is the final common pathway for all of these things. So I really want to do sort of finish on time. So I want to give you just kind of a quick summary of what we had a chance to talk about. There's a lot of different things that can cause the patient to lose consciousness, toxic metabolic trauma, which you're going to hear about later on. The best imaging might be a screening CT scan, and then depending upon the answers you get or don't get from that, you might want to think about an MR. When you have symmetric lesions in the gray matter, you're going to think about some kind of a toxic or metabolic process. These are a panel of things. Just to remind you, this was hyponatremia. This is the patient that had anoxia and hypoxia. I didn't show that case, but again, it's the deep gray matter. This is the patient with a thiamine deficiency here, but I could show you CJD and it would look the same. This is the ethylene glycol. This is the HELP syndrome. This is methanol intoxication. Look at that. Don't they look the same? Two completely different things, one with the toxin, one without, and then we have the carbon monoxide intoxication there. This is a patient with fat embolism, which we also didn't have time to talk about. One of the things that you find in the literature are these mnemonics and acronyms, and so this is the found down AEIOU tips. This is fantastic, especially down here at Disney World, but then I have to remember what all the darn letters stand for in the mnemonic, and I can't really do that. So I've basically sort of run out of time, and I want to thank you all for your attention and thank John for inviting me up here. Thank you all very much for your kind attention.